everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar is being recorded, and the public slide deck will also be made available on our website under the Education tab, and I'll post that link in the chat shortly. Following the presentation today, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, for upcoming LHS events, our next impact seminar will take place on Tuesday, April 4th, with Dr. Priyanka Desai, who is a senior research scientist at NORC, or the National Opinion Research Center at the University of Chicago. And with that, I'll turn it over to Dr. Tim Beebe to introduce our speaker.
Great, thanks, Lindsay. Welcome, everybody. I'm thrilled to be able to introduce today's speaker, Dr. Paula Lozano, who serves as a Senior Associate Medical Director for Research and Translation and Director of the Center for Accelerating Care Transformation, the ACT Center at Kaiser Permanente, Washington. She oversees embedded research in this integrated health system and serves as a bridge between research and clinical operations, something that's near and dear to our heart. Since 2017, she has co-led the design and implementation of an innovative model for continuous learning at the organizational level, accelerating care transformation by helping to integrate research findings into practice in pursuit of the quintuple aim. I've not seen the quintuple aim. I've only seen the quadruple aim. A lot of touch. Dr. Lozano is also Senior Investigator at Kaiser Permanente, Washington Health Research Institute, Adjunct Professor in Health Systems and Population Health at the University of Washington School of Public Health, and she co-directs the ARC and P. Corey funded Catalyst K-12, the training program for learning health system scientists, something that we have. We're both part of 11 member group that has those training programs. After receiving her MD from Harvard Medical School and completing pediatric residency in Seattle Children's, Dr. Lozano practiced pediatrics for 2 decades at Harborview Medical Center, Seattle Children's, Group Health, and KP Washington. Dr. Lozano was a Robert Wood Johnson Clinical Scholar at UW, where she also earned her master's degree in public health. Her research expertise includes health behavior change, childhood obesity, self-management of chronic conditions, and asthma care disparities. Her work has focused on improving healthcare quality through changing the delivery system, supporting clinical decision-making by providers, and supporting patients and parents in health behavior change. Dr. Lozano has conducted U.S. Preventive Services Task Force evidence reviews as part of her KP Research Affiliates EPC. They have an evidence-based practice center, as we do here. Prior to joining KP Washington, formerly Group Health, she served on faculty at the UW's Division of General Pediatrics, where she led the NERSA Primary Care Research Fellowship and taught residents and medical students. So quite a list of accomplishments and experience. So we're very lucky to have her here to share some of that wisdom and speak specifically to this training program that we have. She spearheaded a very nice paper that was just published in Learning Health Systems Sciences, Learning Health Systems Journal. Is it Sciences Systems? Anyways, a really nice compendium of the work of the 11 centers of excellence that are funded under ARC and P. Corey. So I will hand it over to Dr. Lozano to take it from here.
Thank you so much, Tim, and it's great to be here. I've enjoyed this series in the past couple years, and I'm grateful to be invited to speak with you. And thanks to Lindsay for all her support in coming to give you this presentation. I'm going to share my slides, so if you will bear with me. Great. So my name is Paula Lozano. I use she, her pronouns, and I would like this to be a very informal conversation. So if you all have questions, or if there's anything that I said that doesn't make sense, raise your hand. Lindsay will see you and unmute you, and you can ask your question. We've got a discussion session at the end of this presentation, and there's also a place where I'll ask you to weigh in somewhere around the middle. So today we're going to talk about training the next generation of LHS scientists. I'm going to take you back first to 3 years ago this month when COVID hit. And when you think back to March and April of 2022, this was a time when learning health systems around the country sprang into action. And we've seen publications about this. We've talked about this with colleagues. In so many ways, the health systems that we researchers work in turn to us for help. And at KP Washington, the topics were around modeling incidence of COVID-19, figuring out how to set up, design, and evaluate virtual care, looking at predictive models to figure out who was shut in at home and isolated and needing refills on their medications to avoid exacerbations. We also had this a tidal wave of new information coming out about the disease, possible treatments, and diagnosis approaches. So we had to, as scientists, we had to help our colleagues in healthcare synthesize all of this to know what to do from one day to the next. Also, like tracking our utilization and understanding how we could respond to this pandemic, and then more recently figuring out if there are certain medications that may be in limited supply or may have varying indications, understanding who is best poised to benefit from these medications. So huge slew of applications for the LHS approach, and there are many more. And I know that Minnesota really was among the systems that really dug in heavily on an LHS response there to COVID-19. And what I think a lot of us as learning health systems researchers felt at that time is we felt validated. We were like, they need us. They understand how important research is and how important being a learning health system is, not just detached research, but embedded. And I think that we all learned from this. When the situation was urgent, I mean, hard to imagine a more urgent situation. It was all hands on deck. It was researchers elbow to elbow with the care delivery leaders. Our priorities were aligned. I mean, it was so clarifying, like we needed to get through this moment. And at the end of the day, nobody asked about the ROI. And this is something I want to come back to later in the talk, because it's a refrain that we hear as folks who do training in LHS research, is that we want our colleagues in healthcare delivery to understand the ROI. We see the return on investment, but do they see it? And in COVID, boy, that question just wasn't asked. They were like, please help us. So how can we use this example to create a future where we function as well as we did with that alignment and that common sense of purpose as we did in this very terrible pandemic situation. So what I'd like to talk about today is what are some of the challenges that we face doing LHS research and training LHS scientists. I'd also like to talk about some of the solutions that we've run across from a variety of different experiences in the field, and explore some future directions and what this means for us. So today I'll be talking about some insights that come from a few different places. We have, I just 2 months ago saw this fantastic paper by Rob Reed and Sarah Green. And it really encapsulates, I had already started preparing this talk, and it just really clicked for me because so many, it centered around these 8 tensions in learning health systems, and it's in the same journal that Tim alluded to earlier, Learning Health Systems. So I recommend you all take a look at that. And then the ARC-PCORI funded centers of excellence, of which there are 11, Minnesota being one, Catalyst at Kaiser Permanente and UW being the other. one of the others, a lot of our learnings come from that experience. And then finally, I'll talk about some local learnings from our work within Kaiser Permanente, Washington, where we use research capabilities to support our care delivery partners. Then I would love to bring your insights and experiences into the conversation. So before we talk about training learning health systems scientists, let's look at the state of the field. So we're training researchers in a field that's rapidly evolving, and they feel it. I feel like a lot of the early career scientists in learning health systems are fastening their seatbelts because it's a bumpy ride, and it's eventful, let's say. This learning health system concept, it has not reached its full potential at scale. And that's I think just a hard fact about, for those of us who are real enthusiasts and believers and feel a lot of optimism about what LHSs can do, the fact remains that in academic circles like this, people in this webinar and our colleagues, we talk about learning health systems. There are places in the healthcare industry where they're talking about these concepts, but with much less enthusiasm than folks in academia. Also, when you look at the kinds of systems that have been set up in academic medical centers and integrated systems like the VA and like Kaiser Permanente, those are the places where we really have fully developed LHS models, or at least models that are going toward being fully developed. But the generalizability to other populations has not really been demonstrated at scale. And the fact is that it's hard if you don't have resources allocated and you don't have aligned incentives. It's not really easy to build an LHS. So this has been a challenging environment for creating the partnerships that we need and for training these scientists. This relates to Rob and Sarah's paper. Of the 8 tensions, they highlight agreeing on purpose. So going back to the example of the pandemic, we agreed on purpose. And in thinking about that example, there are other features of the partnerships of the COVID-19 situation that allowed us to be successful. So we were fully engaged partners. Our healthcare colleagues emailed us, called us, texted us, invited us to the table, and we were all in, and they wanted us to be there. As researchers, we really wanted to understand what the needs and priorities of the healthcare organization were. We did not have a grant we were writing or a hypothesis we were testing. We were like showing up, trying to help, and needing to understand what our partners' problems were clearly so that we could be most helpful. From that came clear alignment on the goals and what our roles were as researchers. And then we were able to bring that wealth of expertise that we have from quantitative to qualitative and all the different methodologies and approaches and study designs that we could apply in these varied and challenging settings. And then accountability, I think, is really key because there was a huge focus on getting it right, and we held ourselves accountable to act on the findings that we came up with. This would be a time to hear from you all. What did I miss on this list? What else did you all experience during COVID-19, during those early months and couple years where there was this intense focus on the learning health system as a way to do business? You can raise your hand if you have something to add to this list, or maybe something on this list doesn't look right to you, or you would want to emphasize something I've mentioned. I assume that many of you were involved in partnering with your health systems in the early weeks and months of COVID. Oh, it looks like Paul Draws has a comment.
Yeah, I guess it'd be interesting to hear what you think about how much the utter vacuum of knowledge about the disease facilitated this collaboration. Like any other thing we're trying to improve, you've got experts from every which direction, but here it was just a total void of knowledge.
Yeah, that's so interesting. And a void of true knowledge, and then all of the I don't want to say misinformation, but theories and hopes and ivermectin and what was the other malaria drug? At any rate, all of the different ideas, and then about contagion, and is, you know, the role of masking or not masking, and do you wash your groceries, and like just that huge cloud of fear combined with lack of really good solid knowledge. And boy, our infectious disease colleagues were really called to double duty with just synthesizing huge amounts of knowledge that was coming out in the preprint literature, you know, being published incredibly rapidly, and having to filter through, like, what do these studies really mean in a setting where we don't have thorough peer review. I think that is an important element, Paul, and it highlights the role of scientists in applying rigor, and urging caution when the data that are coming out are really preliminary and not ready for us to draw certain conclusions. Our team had monthly meetings with our regional president and the head of our medical group to go through. We had a chart review, evidence synthesis of PubMed and a number of other different databases that we did on a regular basis. And we would meet with our leaders, a small group of scientists would meet with our leaders and say, here's the latest that we have on, you know, the remdesivir trial and the steroid trial, et cetera. And then as vaccines started to come out, the data on those, because it was really week to week, month to month that the data were changing. Any other comments to add here? Well, so these observations from COVID-19 align with what the Reed and Green paper talk about, and you can see there, you know, the understanding, we as researchers need to understand the key business priorities of our partners. It's our job to bring those rigorous analytic approaches, and we should make sure they're rapid and that they're, you know, because it doesn't help if the problem needs to be solved in 2 weeks. Doing something that takes 6 months is not going to be relevant. And being flexible about our methods and drawing, you know, bringing other colleagues in who have complementary methodologic expertise, finding the knowledge that exists in the health system about how the health system is experiencing whatever the problem is, COVID or whatever, is an important part of being responsive researchers. And then servant leader, boy, all of these researchers were working nights and weekends and devoting themselves to this cause. So from the various experiences that I was mentioning earlier, the our experience with training, our experience at KP Washington. I came up with these 5 calls to action because I think that there's a lot that we know that we could do right now, that we could change about how we do business as researchers, that would move forward the field of learning health systems and the important work of training early career scientists in doing this work. I'll go through these one by one in the subsequent slides. But the first one's about centering health equity. Secondly, creating partnerships that are bidirectional and truly embedded. Third, looking at the broader LHS workforce, and I'll tell you what I mean about that. Communication is a huge and underappreciated function in a learning health system. And then coming back to that return on investment topic. Before I tell you about my first call to action, I want to introduce you to our fantastic Catalyst scholars. Catalyst is our acronym for the K-12 Center of Excellence that is led by Kaiser Permanente Washington Health Research Institute in partnership with the University of Washington, the VA of Puget Sound, and Washington State University. These are our wonderful scholars who the 2018 folks have graduated, the 2020 folks, and the 2021 folks are going to be finishing up in September. I'll tell you also a little bit about the program as a whole. We have these 11 centers of excellence around the country. Together, we have trained over 100 scholars, where each one of these centers of excellence has varied relationships with health systems in different settings, including outside of healthcare systems, so some schools and prisons and sort of a broader array of community organizations. And they all have some engagement with health system leaders as partners and or mentors. And our scholars, you can see there, are varied in their disciplines and their methodologies. So this is the paper that Tim and others, all basically program directors from across the 11 centers of excellence, contributed to this paper that came out late last year that describes our experience. And if you want to get a sense for how this program played out, I'd encourage you to take a look at that. But on the left are the core competencies for LHS researchers. And I know that this group is pretty savvy about learning health systems, so I'm not going to go through them one by one. I know that the previous webinars in the series have talked about these. But I do want to point out that the one that's highlighted in blue was not one of the original that was published in 2015 that ARC adopted and moved forward with this K-12 on. This Health and Healthcare Equity and Justice was added by the program directors in 2022 as part of our experience in doing this training. We realized as a group that there was a gap, and so we added that in. And interestingly, that same call for papers that led to the article I just showed you, led our 8 Catalyst scholars to publish a commentary on the gap that they felt as scholars in the area of health equity. And this came out sort of their thinking was happening in parallel to the program director's thinking, but they were all sort of going in the same direction. And I would say that the Catalyst scholars took it a step further. And in addition to talking about integrating health equity throughout the domains of competencies, they really pointed to the scholarly tradition of community-based participatory research. And when you think about partnership, I mean, that's such a big part of what we do as learning health system scientists, and getting at health equity and understanding the needs of the communities that we are trying to serve. There's the whole scholarly tradition of CBPR is actually one that the scholars encouraged us to bring in more fully into learning health system science. So I think that is a really nice contribution, and I encourage you to take a look at that paper for other recommendations around bringing centering health equity in learning health systems research. Our second call to action is, I'm checking the time here because I can get really long-winded on these stories. I think we're doing okay. So this is a story of two of our Catalyst scholars work. So Gwen Lapham is a social work doctoral PhD who was interested in mental health and substance use care for teens. And Gwen and I had worked 5 years earlier to support adult mental health integration at Kaiser Permanente, Washington. And we all sat around a table with our mental health leaders and our primary care leaders and Kathy Bradley, who was the PI of this R18 that Gwen and I were supporting. And we made a decision at that time. We had hoped to do integrated mental health for adults in primary care across KP Washington. Sorry, not for adults, going down to age 13. That was the goal. We said, we know that screening for certain mental health conditions, that there's good evidence going down to age 13. And our mental health leaders looked at us and said, this is all great, and we're all aligned on many, many aspects of this work, but you know what we can't do? We can't do adolescence. It is too complicated. There are many logistical problems with family medicine and pediatrics, and it was just going to be too much. And Gwen and I, who both had a strong interest in the adolescent component of this, were both very disappointed at that time, and also recognized that it was the right decision to do for the health system at that time. And the happy ending to the story is that Gwen was able to come back after we successfully rolled out integrated mental health for adults starting at age 18 across our system. And it was a very successful implementation. And we were able to then layer on top of that the adolescent work. So that was an example of the health system really knowing what it was capable of doing and understanding that we were going to sink the whole initiative if we tried to be too ambitious. So Gwen was able to develop a pilot in 2 clinics that is laying the groundwork for future implementation, really dealing with a lot of issues around confidentiality, which really there are many nuances to doing this in adolescents that would not have been there in adults. And then her colleague, Annie Hoops, who is an adolescent medicine physician, who is a scholar. So Gwen was in our first cohort, Annie's in our third cohort. Before she was a Catalyst scholar, Annie, as an adolescent medicine physician in our system, contributed to the work by helping with user-centered design to ensure that the workflows and the tools that we were developing were going to be patient-centered, family-centered insofar as screening for mental health conditions. So the point of telling you this story is that these are relationships that happen over time. It's bidirectional. Gwen and Annie both contributed greatly to the work of the organization and got a lot out of these partnerships, and were really in conversation with healthcare leaders throughout this whole process. Our third call to action is about the folks besides the early career, or besides the learning health system researchers themselves. When any of our projects that we look at in the Ag Center has a huge team that adds their own unique skills. So actually, not every project has a huge team. Every project has a team, and there's a huge variety in the kinds of talent that we bring to those teams. So we have examples here of folks who are quality improvement advisors, practice facilitators, experts in patient engagement and data analysis. That all of those capabilities are part of what make us as researchers able to do our work. We also, looking over on the healthcare side of the house, we work with service line leaders, folks who are delivering direct patient care, whether they're the community resource specialists you see there, or a nurse, or a pharmacist, our partners in IT, and recognizing that these are all members of the team, I think helps us think about how we move the LHS work forward, we look for opportunities to gather, to celebrate, to make sure that we're still aligned, to discover together, to engage in inquiry together, and that has been productive in this bidirectional learning, because there's so much expertise that we miss out on if we just hang out with the researchers. Our fourth call to action is about communication. So the LHS is very good about stepping away from the paradigm of like, all I need to communicate is my peer-reviewed paper, right? So we all know that is not the only communication and dissemination that is important. And I just wanted to highlight that throughout the whole life cycle of an LHS project, we are well served by being intentional about communicating. So early on, talking with our partners about what is this project? What is it you are asking us to do? What is your question exactly? How do you think we are going to be able to help you? Who's sponsoring this? Like, what leader cares about this project and is going to stand by it 6 months from now, 12 months from now when we run into barriers? Let's make sure that we are coming up with outcomes that matter to that leader. Get clarity on what's your role, what's my role, when are we going to have these these milestones met, what might get in the way. So all of that needs to be done with our care delivery partners. And we need to remember to continue communicating, because sometimes these projects take a long time, and coming up for air and saying, okay, we need to let these folks know what's happening, and let the broader community know, the rest of the organization, oftentimes it allows people to get credit for the hard work that they're doing behind the scenes to design a new intervention, or to work on an evaluation in partnership. Leaders benefit from having visibility to that. And this next slide is just a couple of examples. You're not meant to be able to actually read this, but the point about meaningful communication is, so on the left, we have Annie Hoop's paper about the adolescent integrated mental health user-centered design work. So she submitted this paper. I think it's under review, and actually it might have gotten accepted. At any rate, we also wanted to share our findings with our care delivery partners. And we know that a paper is not the best way to do that. So we took the findings, and our communications team created this 2-page summary, which is really easy to digest. And then for different venues, a 3-slide PowerPoint. So you may have people on your team who have communication skills, or you may be able to outsource and access communication expertise in other parts of your organization. But I think it's worth asking yourselves, how do you make sure that your communication is meaningful to the stakeholders that are important? All right, and I told you we'd come back to the return on investment. And I don't know, Tim, if you get asked this question a lot, but whenever we're kind of sitting around talking about, with colleagues around the country about the challenges in learning health systems research, the question so frequently comes up, like, why don't our leaders understand the ROI? I need to show ROI to continue to get support, but my leaders don't get it. What's going to help my leaders get it? And going back to that COVID-19 example, and relying on this recent point about communication, we shouldn't be, this ROI should not be something we talk about at the end of the project. It's something we talk about at the beginning. And we ask our stakeholders, what do you need? And is this work that we're about to embark on the right work? That's the ROI from square one, right? And then as we move forward, are we still on the right track? Like, oh, we encountered some barriers. This didn't go the way we planned. Are we going to adjust? And if we adjust, are we still aligned with our sponsors? And then as we get findings, sharing them and then holding our leader accountable to say, look, way back when you asked us to do this, or we agreed that we would do this together. And here we have this finding that actually this pilot is not as effective as we thought, or it's effective for some people and not for other people. How are you going to use this to inform care? Let's make sense of this together. So I think that thinking about the ROI longitudinally over time and making sure that we're communicating about it all the way through kind of makes it a non-issue. And that's been our experience. So, this is the classic LHS approach, is to think about, okay, we've got traditional academic success, but we also want to accelerate transformational health system change. This is the model that we published a couple of years ago, also in learning health systems, that I'm just highlighting here the outcomes, and these are the important outcomes, I think, for a learning health system. And what's in here is the quintuple aim. So population health, experience of care, costs of care, care team work life, and equity, and making sure that we as learning health system scientists are connecting, like all the work that we do is related to one or more of these aims in the quintuple aim, right? That's not news for us, but we need to make sure that our partners in care delivery see that connection from the very beginning of a project. So that is, oh, look at that, 10:41, good timing. So that is that's the end of my presentation. And I would like to hear what you all think learning health systems, and in particular training programs, should be doing differently to address these challenges. And while you're thinking about that, I would like to acknowledge a cast of thousands. So locally, our Catalyst K-12 project team and our fantastic scholars, our Kaiser Permanente Washington partners on the healthcare system side, and our research project staff who are multi-talented and really committed and fun folks. Also, because many of the lessons learned here came from the K-12, I need to tip my hat to the fantastic colleagues around the country at these other 10 centers of excellence, including the good folks here in Minnesota. I would love to know, what have you all been doing to advance LHS in your areas, in your systems, and what challenges are you seeing, and what does the field need right now?
Thank you, Dr. Lozano. And so we do have plenty of time left for Q&A, and as they're thinking about that particular question, there is one question that came into the Q&A. Says, thanks for your talk. How do you respond to the concerns about the differences in how LHS is wielded as a terminology and taxonomy? For example, LHS, LHS approach, LHS model, LHS project, patient-centered LHS, integrated LHS.
Oh, that's a fun question. I haven't thought about that as a problem, but you're right. I mean, it's being used a lot, and maybe this is what happens when an idea. You know what? I'm going to stop sharing my screen because that way I can see those of you who are. There we go. And I don't think you're going to need to see any of my slides again, but I can always screen share if needed. My observation about the taxonomy, well, first I'll say that one of the things that happens when something gets some traction, get a popular idea, is that people start using the term a lot. And there is the danger, and I think this is what the commenter may be alluding to a little bit, of diluting the idea and having it be kind of a little bit meaningless because it's not, people aren't all clear on what we mean when we say LHS. So I would like to argue for tightening up our definition and making sure, Nick, that we are consistent with what we mean. The ARC definition is a system in which incentives are aligned and internal data and internal experiences are used to improve health. That is a learning health system. And I don't say I work in a learning health system. I say I aspire to have my organization be a learning health system. And I think a lot of us use that kind of terminology, like we're afraid to say we are a learning health system because we're all on this developmental trajectory and we are trying really hard. And in pockets, I say, oh, this feels like an LHS over here, and this over here feels like an LHS, but there's still some, there's still a ways to go. So I think it's definitely worth being humble and using the term in that way. But I think what you're talking about, Nick, is the LHS approach, the LHS model. There have been a lot of models that have been published out there. I think when we published our paper, there had been 17 models, and now there are some more. And one of the points we make in our paper is that it's time to start measuring. It's time to start moving beyond this model or that model, and just saying, let's start figuring out, are we getting the outcomes that we want from the work that we're doing toward learning health systems? And I don't think we probably need additional ways of describing essentially the same model. But the taxonomy that I find myself struggling with a lot is LHS research and LHS practice. And I will tell you what I mean by that. What we do in the ACT Center, where we have internal funding from our health plan, and that pays for FTE of programmers and project managers and practice facilitators. And that is, in that situation, we take the servant leader approach 100%, because we don't have an RO1 that's funding this work. We are literally saying, somebody called me up and said they need help with a predictive model. They need help with an evaluation. And so I'm building a team to help address that problem. That to me is LHS practice, because it is not driven by a research question. And we've published many papers from that kind of work. So I think that there is generalizable knowledge that comes from that, but it is not investigator initiated, hypothesis driven, extramurally funded research. Whereas LHS research is more investigator driven. And I'm making this dichotomy seem really stark when actually there is a lot of gray zone. And I think what's challenging for early career researchers is that they need to get independent funding. And it's really important for them to get preliminary data and get their R01, and to do that in a way that is really in partnership with healthcare. It's putting a lot on those early career researchers, frankly. So I've gone off on a little bit of a soapbox on Nick's question here, but I think that the point is that this term is popping up in a lot of places, and it is good for us to be really crisp around what we think the definition of it is. And I would refer you to ARC for the standard definition. I hope that answers your question, Nick.
Are there any other questions? If you'd like to raise your hand, I can unmute you. Dr. Beebe.
Great presentation, Paula. So, I think part of this definitional lack of clarity on the definitions and the nomenclature is, again, you've hit upon, what's a learning health system and what's learning health system science or learning health systems research. There's wide variety in what are the requisite elements to become a learning health system, right? You see declarations of that in brochures, but there are certain things that, are part of that. And what is learning health systems science and learning health systems research? And part of that is, again, there's even like camps that reflect an interpretation of that. Some view that, you set up the systems and data structures and, curate a platform, and then you're an LHS, I would argue that it's that plus, and I would argue more importantly, maybe because I'm a sociologist, the social infrastructure of an LHS is as important. It's well placed to convene and interact with clinical practice and research, which have been typically siloed, and a place to co-create. So the research is the study in healthcare as opposed to the study of healthcare. So it's endogenous versus exogenous. And part of the challenge doing this work is, some of the clinical leaders in the C-suite see research as a pejorative, because when you talk about research, it's like it's slow, expensive. You interact with people that overstate the obvious with inaccessible language, like endogenous and exogenous. So really making yourself a partner, and that CBPR perspective, the systems-based participatory research, is so critical to try to, with humility, work with the clinical practice to respond of needs of importance to them. So it's a pull from the practice, and that lends itself to a higher likelihood of uptake and integration and implementation. So there's a lot of challenges with the nomenclature, what this is, what it's not. Again, it's really kind of perverse to say that, but COVID did us a lot of favors, and it showed us in practice,
Right.
The need for rapid cycle learning, rapid cycle curation of evidence, rapid cycle bringing things into the EHR like nudges and things of that nature. So it really made manifest that research is not this sort of ivory tower slow thing where the endpoint is solely publication. It should be publication, so you're adding generalizable knowledge, but you're providing the best evidence to the practice. So it's this quest for the twofer. So I think that there's a lot of lack of clarity on, LHS research, and just trying to change hearts and minds around like this is research that actually can benefit the practice, but also be undertaken in a manner that leads to generalizable knowledge, which confers benefit for reputation, all these other things too. So I think that the sort of you've hit on some really important issues that I've seen people confuse, at least from my perspective, what they're talking about.
Yeah, I couldn't have said it better myself. I like that. I like that framing of it. And you mentioned, is a fantastic data platform where you can learn from every patient and capture this the data in real time. Is that sufficient? Well, and I would agree with you that it does not make a learning health system. And I think it is interesting to think about how to make that a participatory process. So when you created that platform, who was at the table? Was it researchers at the table? Was it also healthcare partners? Were there patients and families at the table? So I think that there are ways. I think we're constantly finding more ways to live up to that ideal. And I do think, when you look around the country and you see the groups that are using the LHS term to define themselves, they do have different typologies. There are some that are more, it's all about the EHR and the data platform. And I think we have a lot to learn from them and the work that they're doing. I think we are a ways away from what Matthew's asking about, where we would have a designation of LHS, like the patient centered medical home or stroke centers, trauma centers. How do you get designated as a learning health system? I think there's still a lot of heterogeneity in the way that those concepts are being brought to life. And frankly, I think we need to, in all of these, the case of stroke, trauma, PCMH, first came the evidence that this helped some element of the quintuple aim, survival in stroke or trauma, whatever. And then came the effort from, national bodies to create these designations. So, I think we're showing our ROI at a project level. I think as a field, the programmatic ROI is still a ways away. So I'm not predicting designation levels at this time. And Dylan is saying at KP Washington Health Research Institute, is Cerner that? No, we use Epic. Dylan, and you're asking because Cerner Learning Health Platform. Oh, that's interesting. Yeah, the Epic, we've done a lot of work within Epic around predictive models, and I don't know if there are folks in this webinar today who do a lot of predictive modeling, but our team that is devoted to modeling work has had to do a deep dive into Epic, and I am not on that team, so I am probably going to say something wrong here, but the technical aspect of building these predictive models into Epic, Epic does not make it easy, and I think that is actually a whole conversation. That's
exactly what I was asking about.
Yeah,
the vendor doesn't share everything, and sometimes there's
exactly.
Yeah, I mean, sometimes it's great because they have the power and the infrastructure set up already, but
yeah. So we've had to really invest in understanding what we're capable of doing, and like their models are black boxes. And so what we've typically done is we take an Epic model for predicting whatever, no shows, hospitalization, whatever. We test it in our population. We find that it does mediocre. We develop our own model and find that it does a lot better. So we haven't used the Epic models for anything, I think, thus far. We always test it first so that we have an understanding of, well, like that would be the easiest thing if we could just use that. But we end up developing our own and validating it in our population.
Cool. Very cool.
Yeah, thanks for that question, Bill.
Yeah, thanks very much.
Great. Well,
Yep, we are
Getting
at
to the end of our time.
Yes, yeah. So thank you very much, Dr. Lozano, for taking the time to present today at the CLHSS Impact Seminar, and thank you everyone for attending. Again, in closing, please join us for our next seminar, which is on Tuesday, April 4th at noon Central Time, where we will be joined by Dr. Priyanka Desai. So this concludes our presentation. See you next time.
Thanks,
Great.
Paula.
Thank you, everyone. Good to see you.